the drugs you were talking about are for pretty much run-of-the-mill customers, right? These are the people with HIV who are not exceptional and don't have exceptional medical issues. But there are some carve-outs, right, in the DHHS guidelines for individual patient characteristics. What are they, for example?
Well, so there is a non-nucleoside reverse transcriptase inhibitor, rilpivirine, that the clinical data looks very compelling and good, particularly in people who have viral loads at baseline less than 100,000. So there's an allowance or a carve-out, if you will, for that rilpivirine-based regimen in the eyes of the DHHS guidelines. We also have had to struggle with non-adherence issues through the years. For whatever reason, complicated side effects, complicated dosing schedules, and multiple pills that led people to miss doses and then develop resistance to their drugs. And there's a class of drugs, protease inhibitors, and specifically darunavir-based regimens that the DHHS guidelines have singled out as having a special role for people that may have problems with adherence or may be prone to missed doses.
So what you're telling me is that there are some drugs which are less likely to develop resistance than others. Are they more expensive, the resistance-resistant drug?
It's hard to say. You have to look at really the cost of the regimen when you're making comparisons. So, you know, it's sometimes difficult to look at one drug versus another.
I mean, if they were, it would make sense to reserve those drugs which are specifically targeted for individuals who are likely to get resistance to those patients, right? Especially if they're more expensive.
Well, that's it. And Ellie touched on this a minute ago. When we're setting up formularies, we are looking at efficacy, safety, cost, dosing, utilization, those types of things. But formularies are population tools. So we don't want to stand in the way. So what we'd like to do is we'd like to get to a position where maybe we can have some preferred drugs based on cost effectiveness, so a combination of clinical and cost. But there's always going to be an exception process to that. Again, there's no way. It's never going to be one size fits all. So if there's evidence to support that a certain drug or a certain regimen is better for a certain patient, then absolutely.
All right. So globally, from the 10,000-foot view, these new guidelines, do they change the landscape for the third-party payer?
I would say fundamentally no. I think we've had a lot of preferred regimens in the past, but a lot of alternatives. So there's always a question, well, what's the difference between a preferred and an alternative regimen? But the new regimens just move towards more integrase inhibitors, but it's always a challenge from a formula perspective to keep up with the guidelines. But at the same time, if we have access in some manner to these drugs, I don't think it does. The question is maybe if it gets too narrow and it's maybe one manufacturer, then we're not going to have an opportunity to address the increasing price component.
But again, my challenge to you, Jeff, and my frustration perhaps with you, not you personally, but with the payer situation, is that I feel like they haven't kept up as promptly and quickly as they could with guideline changes and with new products and new drugs. What I've seen over the last few years is when new drugs come on the market, they really have a benefit. They have a benefit from safety, from simplicity, from less side effects, and it's very compelling to use them.
Yeah, I would actually say it's not on purpose. It's just because this has been a hands-off category, and I just know, looking at a lot of my colleagues, they're not managing these categories, so they just don't get around to it. They put it on formulary and that's it. I think actually refocusing on collaboration and actually formulary managing this might actually speed things up and get us to a better spot if we can have these types of conversations. But right now, I think the fear is we can't do anything, so we don't have to look at that.